We are live, sir.
Hello, everybody. Greetings from Indian Medical Association. And I'm Dr. K.K. Agarwal. This is going to be our 30th meeting in a row. Basic purpose is to come out with resource material for our IMA members. I'm now handing it over to our Secretary General, Dr. R.V. Asokan, to say a few words.
Thank you, sir. I think this is becoming an encyclopedia on COVID and its management. The topic for today is fertility and ART practice during COVID-19. And we will have Dr. Krishkesh Pai, Director of Bloom IVF Group Administration, Foxy Mandyanta Project Director, Past President ISAR and IAG. And he has consented to be the faculty. I hope he has joined. Over to Dr. K.K. Agarwal, sir, for introduction of the topic.
Thank you, Dr. Ashokan. Thank you, Jay Krishnan, Dr. Sanchita, my colleague Ritu, and our faculty, Dr. Rishikesh Pai, who is also going to take over as the Foxy president in the coming time. He has served also as a Secretary General of the Foxy, an international expert in the field of fertility. The objective of this material is to come out with guidelines. What is the current situation of crossing over of the coronavirus through the placenta? B, how safe are reproduction technologies? How safe are IVF in this particular situation? To answer all this, we will have a 25 minutes presentation by Dr. Rishikesh Pai, and then we will have a dialogue with him on common question answer sessions. I present to you Dr. Rishikesh.
Can I have the screen share, sir? I need the screen share.
Done, sir.
Okay. So I will. Can you hear me? And you can see the screen. Hello. Can you see the screen? Hello.
Sir, screen is visible, but your slides are not visible. Sir.
Yeah. I'll start the slides. Is the screen visible now? The slides are visible?
Sir, screen is visible.
Yeah. So basically, I'm grateful to the Indian Medical Association, Dr. Agarwal, and all of you here. I will, when the COVID-19 started, there was a shutdown guidance that was given by there was a postponement of procedures except emergencies such as fertility preservation or ectopic pregnancy. We were told to avoid procedures in immunocompromised states, to conserve all healthcare resources for COVID patients, freeze all for those patients who were COVID negative and already. And so we had some patients under stimulation. So the instruction was given to freeze the embryos, cancel if patient is COVID positive, maintain threadbare staff, teleconsultation, and liquid nitrogen top up. Means, all the embryos and eggs are in liquid nitrogen. So the only objective was to see that every week, for example, I have 6 centers, so I had to really go out of my way. It was really tough for me to see that the liquid nitrogen fellow came and topped up the containers. Otherwise, all the embryos and eggs which were frozen would have got destroyed. And freeze all using multiple dilutions, closed method, separate liquid nitrogen container if available, sterile liquid nitrogen, and vapor freezing also was advocated. So because we didn't know whether this COVID was very infective or what was it. So we were not aware. So these were the instructions that were given. Then on the 23rd of April, 2020.
Pai sir, sorry to disturb you, but we are able to see your Zoom screen, not your slides, sir.
You can't see my slides?
No, so we can see on your Zoom screen.
Okay. I'll just do it again. 1 minute. I'll just share the screen again. Can you see? Can you see now?
Not now, sir.
No, sir.
Can you see
Sir,
the
sir,
slide?
first open your slides, then click on share screen, sir.
You can't still see the slides?
No, no, sir.
Okay, I'll just... I don't know what is the problem.
Can you pass on your slides to Ritu, and Ritu can then show it?
No, I'll just, sir, what I'll do is I'll just, I'll just try again.
Otherwise, you WhatsApp it to Ritu. Ritu can share it.
Can you see now?
No, not yet.
What I'll do, I'll come back. Maybe now you can see.
Yes, yes.
You see?
Yes, yes.
Okay. So the guidance was to postpone the procedures. I have just now gone through it. So it was realized that there was no evidence of viremia was seen as in the presence in uterus, ovary, testes, or semen. COVID-19 is not present in follicular fluid or seminal plasma, nor was it associated with gametes or embryos. Evidence of ACE receptors were seen in the epiblast cells of the blastocysts as compared to early embryos. There was no evidence of transmission to fetus in the first trimester, and there was most probably no teratogenicity, and there was a very low probability of perinatal transmission or breast milk transmission. So the HD, which is a European society and which is a very important IVF society in the world, it is based in Europe and represents all the European countries. They came out with a guideline on 23rd of April. And what they said that there should be discussion, agreement, and consent to start the treatment between staff, patient, and doctors. There should be access to advice and treatment. There should be adaptation of the ART services. The cycle should be planned properly, and there should be a code of conduct for staff and patients. And hence, our group started OPD in mid-May, and the procedures were started by the first week of June. So there was an understanding that high-risk patients like diabetes, hypertension, those using immunosuppressant drugs, patients on transplant, and having various diseases of the lung, liver, or kidney should not start treatment until it was deemed safe to do so. All patient donors were offered a choice to proceed with or postpone their ART treatment, and we had to document the patient preference. And then there was a prioritization of patients. So emergency patients, like patients who were undergoing chemotherapy and who needed fertility preservation for cancer, or patients with low ovarian reserve, advanced age, and those facing extirpative pelvic surgeries, patients with low semen count. These were all prioritized patients, and patients and donors were to be comprehensively informed, clearly understanding the risks related to COVID-19 disease, and acknowledge the increased risk in case of infection during pregnancy. Patients must also be informed how to reduce the risk of infection, and they had to sign a code of conduct. So patient and staff education was very important, that they had to be told that what is COVID-19, what is the importance of distancing, importance of minimizing contact, situations, how to wear the PPEs and when to wear them, correct method to use them, and possibly that treatment may need to be discontinued if a high-risk clinical situation arises during the treatment. So these were some of the preventive methods that were told to all the patients and the staff about that COVID survives in air for 3 hours on doctor. If you read Dr. Agarwal's daily email, you'll know all of that. 4 hours on copper, 24 hours on cardboard, 72 hours on metal, social distancing of 3 to 6 feet. Then the 5 principles of hygiene, staying at home, distancing, hand hygiene, face mask, and respiratory hygiene, and then how to clean the surfaces, and what about things about quarantining of the individuals. They were also explained about the PPE, and so in the OPD, when we see the patient, we were told to wear that thermometer should be there for temperature screening, hand sanitization, pulse oximeter should be there for oxygen testing, and there should be appropriate physical screen protection. And most probably, the doctor should wear surgical masks, glasses of face shield, and nitrile gloves. If you need to do any clinical examination of blood collection or ultrasound, or you want to do IUI in the OPD, You can wear a surgical mask, the same thing as the OPD, but you can add a plastic apron or disposable gown when doing the procedure. If there is a short ovum pickup, short procedure, most of the IVF have got oocyte retrieval, which is about short GA. So in those patients, you use a surgical mask with a glasses of face shield, nitrile gloves or latex gloves. You can if you wear latex, you need to wear double gloves, and you can wear a disposable gown. Only in those patients where there is aerosol generation, in those patients only N95 mask can be. But in our group, we normally, when we are in the operation theater, we are using an N95 mask along with a surgical mask on top. So this is what was advocated. In the embryology, all the embryologists were told to wear a surgical mask, glasses, and nitrile gloves. So the triage questionnaire was very important, and this is the HT triage questionnaire. Actually, I am on the ICMR committee for the guidelines of infertility and ERT, but because of the a lot of pressure on the ICMR, they have not come out with the guideline. But the triage questionnaire, which they have, because I was already in the meeting, so in the guideline, the same questionnaire which has been advocated by HT has been put by the ICMR as well. And these are the questions number 1 to 8 and going till 13, which are there in the ICMR guideline as well. I had added these additional 3 questionnaires to the triage. One was whether you have downloaded Arogya Setu app, whether you are staying in a dangerous zone, and are you staying in a containment area. But nowadays, all these 3 things are, I don't know, most people are not using the Arogya Setu app. Then, this is as far as the various tests are concerned. But in our group, and everywhere, RT-PCR is the gold standard, and we are not using any other test. In fact, in Lilavati Hospital, they are adding 1-2 more tests also. But as far as general tests are concerned, the RT-PCR is the gold standard. What about the adaptation of the center? So redesigning of the waiting room and working space were done to guarantee appropriate distancing and ventilation. Please, we had to replace the air condition with air exchange machine, because AC normally circulates the air. So if you are going to have a AC, you need to have a filtration system, which you should put in there are various filtration systems available. But what I took a decision was to put UV lights all over the clinics and all over the indoor and the operation theaters. And if you put a 38 watt 250 nm wavelength UV light and run it for 15 to 30 minutes, all the aerosol, because now the discussion is that the transmission may be through micro droplets in the air, so this will kill it. So what we do is that we in between 2 operation pickups or 2 surgical procedures, we run the UV lights for at least 30 minutes. All of us go out, and then we come back and we do the next procedure. So this is what we do. Subdivision of staff. So we divided the staff into mini teams, because it was advocated all over the world that if suppose one team member or 2 members fall sick because of COVID positive, the other team can come in. So in our group also, we divided the teams into different teams, so that backup team stays at home for 15 days and one of the team runs the unit. So we have backup team in all the centers. So we run them 15 days on and 15 days off. Telemedicine was all for all. The steps and management of appointments were according to specific timetables, as well as scan management and blood tests also. So in my unit nowadays, and actually I have got this, it's a fantastic way. So even after the COVID goes away, we are going to use the same way. So in our unit nowadays, if the patient comes we do a consultation. On the consultation only, we tell them what test to do. We inform the pathologist. They go to their home and they collect the blood. We tell them to go to the nearby sonologist. So we have identified in Mumbai at least 15-20 sonologists. So whichever sonologist is near to them. In the olden days, they used to come to our sonologist. All the way is to come to Lilavati. Now I send them to the local sonologist. So after that is done, only for one time they come to the clinic. So after all the investigations, ultrasound, everything is done, they come only once to the clinic and they are explained. And then when the stimulation is going on, everything is done by the local sonologist. The medicine, we reach them to the daily medicine, we reach them to their houses. So, and they only come directly for the worm pickup. So this has become, because of this, what has happened, patient burden. In the olden days, they used to come every day to the IVF center. We used to do the scans, etc. That has been totally eliminated. And this I'm going to continue in the future. even if the COVID goes down, this is going to be my new normal. Because by this method, you know, what was happening for a person like me who's now in IVF for 30 years, slowly, because there were so many, when I started IVF, there were only 7 centers who were doing IVF. Now there are 3,000 centers. So slowly, people stop coming, though they want to come to us, but because of the repeated IVF cycles, they have to postpone it. So now we are going to have these satellite centers where they go, and the local sonologist will be trained, and he will do their monitoring. The medicine will be reached to their houses, and they will come only for the procedure to the lab. So this is the new normal, which we will continue also later on. So adaptation of the center was very important. So we need limitation of number of persons of visit. So we nowadays, as I told you, we avoid couple consult. Normally we used to have husband and wife sitting. Now husband sits in the car. We don't even call the patient up. We call only one couple at a time up. The patient comes and sits in the OPD, and then she comes and the doctor consults, and we reduce because we have got all the teleconsultation, all the papers, we minimize it to less than 5 minutes. Within 5 minutes, we see that the patient goes off. So, but the patient wants to see the doctor at least once. So there is a comfort. Okay, at least I've seen the doctor once. So that is the comfort zone. So PP and sanitation device for patient and staff, and we have placed barriers here. You can see here, these are the glass barriers that have been placed. Unfortunately, because of these barriers, there is a barrier. Psychological barrier is also there between the doctor and the patient, unfortunately. But what to do? So these barriers have been placed everywhere, and the center adaptation has been done. So as I told you, that staff, all the there is a subdivision of the staff into mini teams. So I have divided the team. So if recently 1 or 2, 3 people fell sick, so I totally quarantined all those people, and I brought the other half of the staff which was sitting in the house. So we can do that. So dual. If you don't have that much staff, you should have understanding with other IVF centers. So it's very important. Then what I also done is that I don't allow them to come by public transport. So I tell them that either you stay in the hospital and we'll take care of your food, everything. Because if the staff will go up and down in public transport, they are going to become positive. Or otherwise, for example, in New Delhi, in our Fortis center, I have arranged a private vehicle for them. So all the staff is picked up every day from their houses and brought, so that we minimize, because otherwise if they go by public transport, they are going to get infected, and I'm going to have a major headache on my hand. So arrangements are made to either stay in the nearby place, or so we have to spend more money on them. We have to adjust the worst shifts, and we have to train them in operating procedures, and a specific training has to be also given. Then the triage. So now triage is very important, and this has been advocated, and this is the same triage which is there going to be in the ICMR guideline, which has not yet been released for ART and infertility. But 2 weeks prior, suppose we want to start treatment of a patient, 2 weeks prior, we will do the triage. If triage is positive, we will do RT-PCR. If RT-PCR is positive, we'll cancel the cycle. Then after 2 weeks, when the second day of period, when we actually start them on ovarian stimulation, just prior to starting the treatment, we again will do the RT-PCR on husband and wife in all those patients who are undergoing either IUI or IVF. And if there is a positive, we'll cancel the cycle. Then after the second day, we give them daily injections. As I told you, the injections are reached to their houses now. We don't allow them to even come to the chemist. We give them prescription to the chemist, and chemists go. In Bombay, we have got a new service which is called the V-Fast service. You can tell anything, even in 50. Suppose there is a 3 buildings away, there is someone, you can just phone them and they will even deliver 3 buildings away. So this is a new service that has come into Bombay. It's called the V-Fast service. So we use the service, and based on the radius, they charge you the money. So the deliveries of the medicines along with the prescription and all is done through the V-Fast service. Then, as I told you, after the second day of triage, then we start the stimulation. Throughout the stimulation, if we tell them to do triage. If triage is positive at any point of the stimulation, we'll do an RT-PCR test again. If RT-PCR is positive, we'll cancel the cycle. If after 8 days of ovarian stimulation, the RT-PCR test is negative, then just before the final HCG injection, normally we give a HCG injection and do the pickup after 36 hours. that is oocyte retrieval is done 36 hours after the HCG. So just before giving the HCG injection, we will do the last RT-PCR on husband and wife. If any one of them is positive, we'll cancel the cycle. We also are counseling them that if suppose the cycle is cancelled and if they are spending medicine, suppose they are spending medicine of 15,000 and last moment RT-PCR is positive and you cancel the cycle, they are going to be very unhappy. So we have told them that we will give them a lot of discount in the next cycle. So we counsel them that don't worry, if there is a positive pay and cycle is cancelled, we will take care of it and we will see to it that they get a discount in the next cycle. So that way they are at least, not under tension. So this is actually, I'm just writing a paper for the, there's a institute, ISSRF organization, and they are coming out. So we are writing a paper. So these are some of the units in Mumbai, Navi Mumbai, Delhi, Gurgaon, and Mohali. And this is the data of June and July. And just before I came on this, I also collected the data of Delhi for the August and September. So this, I would like you to concentrate on the Delhi unit. So in the Delhi unit, in June and July, we had 19 pickups. So the day 2 of husband and wife, 19 were tested and 1 came out to be positive in the one when they tested. So 1, we cancelled that couple. After 8 days of stimulation, 18 had remained. We did the 18 tests. Then again, for IUI, there were 6 only, because that time there were not too many people. People had just started coming. So our numbers were lesser comparatively. And then after, if you look at the frozen embryo transfer, we did 15 during those days, And so the total positive was only 1 was positive in August and June and July in Delhi. And the prevalence rate, if you calculate, because was 1.2%, because all of these patients, we had tested them. So prevalence rate of the disease of asymptomatic, they are all asymptomatic, and we tested them and we picked up positive was in 1.2%. While in the August, September, you can see this figure. Now the figure has gone up. Instead of 19, we have done 28 pickups in August and September. And when we did the test on the second day of the stimulation, 1 came out positive. Then on the 8th day, when we did the repeat test of the remaining 18, again 1 came out positive. Okay, and during the IUI, 1 has come out positive, and in frozen embryo transfers, out of 15, 1 has come positive. So the prevalence is 4. 4 came out positive in August and September, and the prevalence rate has gone up to 2.6%. So there is a slight jump in the prevalence rate in Delhi. While Mumbai result I would have shown you, but I think the Mumbai result, there is a decrease. So in the first June and July, the Mumbai had 6.5% prevalence rate. That has actually gone down, because I was talking to my doctors, what is the prevalence rate. So because we have rigorously tested all the patients of RT-PCR, and this is the prevalence rate. So it actually also reflects on what is the prevalence in Mumbai and Delhi. So I personally feel that Delhi prevalence has gone up little bit and Mumbai prevalence has slowly gone little down, because our units are both we have the best of both worlds. We are in both Delhi and Mumbai. So we can actually compare the two metros very well. So ovarian stimulation monitoring is very important. So once you know all this, then these slides don't have much importance. As I told you, home self-administration of medicine is now become a norm. And as I told you, medicine refund to be given if cycle is cancelled halfway through. So we don't give full refund, but what we are doing is we are totally discounting the medicine, so that if a cycle is cancelled, we tell the patient, don't worry, we will take care of you. So because of that, the patients are coming. Because, the IVF, cosmetic surgery. See, we have got 2 main streams of work in our life. One is the emergency work, like deliveries and all. Or you have got patients who have cardiac problem, heart problem. They have to get admitted. But a lot of medicine is based on elective work. And if the elective work goes away, there will be major financial problem for all of us. In fact, I've had a massive financial, my work has fallen by 50%, and I had to take care of my labs, my rentals, my pays for my patient doctors, my pays for my embryologists. So it's been a major. So we have to bring the elective work back, because elective work is very important, not only for the doctors, but for the pharmaceuticals as well, because most of the emergency medicine is under price control. Only the elective medicine is not under price control. How are the pharmas going to otherwise survive? How are the doctors going to survive? How are the hospitals going to survive? We have to bring the even elective work back to our. Coming back to the operation theatre, negative pressure lab is very important. And we have got positive pressure, we have got HEPA filters in the lab. And as I told you, you must do as much as work in conscious sedation, and aerosol generating procedures should be avoided. And then, as I told you, we have a gap of 20 to 30. It's a rule, because the two most dangerous people in our life at present are two people. One is the anesthetist. 3 of my anesthetists have been positive. So they go from place to place. So anesthetists are highly areas of. So I have told the anesthetist that you please don't even change. Just put the cover, put your mask, and don't change. So anesthetist, and the second person who can give positivity to the patient is the sonologist, the ultrasound, because everyone goes to the ultrasound department, and most of the ultrasound units are small, narrow, dingy. Now we'll have to change that structure. We'll have to make the ultrasound room very large, ventilated. We'll have to have air handling units, because these are the two pressure points, I feel, where transmission can take place. Infection transmission, COVID transmission can take place. Again, as I told you, oocyte retrieval, and I don't want to go into the details of it, but they are short GA procedures. So long as there is no aerosol generation, we don't bother. We do it very quickly, and between procedures, we see to it that we do massive UV light sterilization. So for 30 minutes, everyone goes out, and when they go out, I would warn them. I said, please don't even stand near each other. No putting your mask down. You go out, stand at different places. Many of the time we have got this. We go and let's have a cup of tea together. Let's cut a birthday cake together. That is the time when we put our guard down, and we can all get infected. So it's very important to see that we don't lower our guard at any point in the time when we are doing our elective work. Of course, in the laboratory, we have got air handling units. So the advantage of AHU is that the air is changed in the lab every 6 to 10 minutes. So the air handling unit is so we have all our IVF centers have HEPA filters. And so we are not bothered about the infection in the laboratory as such. And as I told you, embryo transfer is also. So the code of conduct to staff and patients is very important. All staff members and patients are instructed to avoid unnecessary exposure, both at work and in private. Each service will prepare compulsory instructions of staff. Attendance at work will be tied to respecting the code of conduct. I make them sign the code of conduct also as much as possible. And it's very important to truthfully share all information, comply with any requirements related to testing, restrict movements to that which is absolutely essential, practice social distancing even at the house. And as I told you, I do a lot of things like picking them up from their houses, ensuring masking. We make staff read and abide to the SOPs, comply with quarantine requirement, not create, disturb, spread or forward fake news, etc. These are all code of conduct things, and these are the modifications. So I have got this 10 times a day hand washing, social distancing, 6-foot rule. Mask should be 2-layered. This is better. Dr. Agarwal will tell you better than me, but screening is very important. Triage, temperature and testing. And if you have any problem, you must stay at home. Recently, I don't want to tell you of this, but there are problems. Our people don't work properly many times. Can you hear me? Hello?
Yes, go ahead.
So I'm at the last. So changes in your lifestyle. I think we are looking at a 2-year problem. Though our curve is flattening, we are now at 40, 50,000, but we don't know what is going to work. Economy cannot be devastated. If we lift the lockdown or we don't lift, it is like a tussle, and death is not good for the economy as well. And so I think responsible behavior will prevent you from killing others. We need to be responsible. Otherwise, we'll end up killing others. We need to have a mass education program. I feel that is still not there. We should have a massive mass education program. But yesterday, actually, to tell you the truth, I went to the dentist for the first time. And when I was on when I went down on the road, I was standing outside the dental clinic. I could see in Mumbai, all the people who were walking on the roads were having the mask on. So I was quite happy. So we need to consolidate our practice. This is a big problem because, my practice, for example, has fallen down by 50%. Can you imagine a 50% drop in the practice with 2 months of lockdown? Like every day from morning to evening, I'm working on how to take care of my practice, how to take care of the staff, whom to lay off, what to do. Now the Diwali is coming. Should I give them a bonus or not? These are questions where there is no answer. This is the first time in our life that this is happening. Don't compromise on marketing. But when in 2008, when we had the slowdown, that time I had come across Mr. Godrej's interview. And he had said that when there is a crisis in your life, don't compromise on marketing and technological upgrade. You need to go out of your way to spend more money to see that your business is more aggressively done. So your practice, don't try to scringe and scrounge. This is the time when instead of saving, you should be spending more money. Long-term financial planning is very important, because now what has happened, suddenly many of us who are in their 50s and 60s, suddenly we are staring at a total depletion of our saving. And unlike the West, we don't have any social security. So how are we going to do the long-term financial planning? Conservation of resources and savings is very important. So we'll have to be more. Now, to give an example, my car is there. I'm wondering whether I need 4 cars. So I was thinking I'll sell off one of the cars, because it's very important to conserve our resources. And one has to go back to school and relearn and retrain yourself. We will have to all evolve new. See, I feel that we doctors are very intelligent people. A doctor can do a lawyer job. He can do an engineer job. He can even sweep the floor. He can do a chaprasi job, but they can't do our job. So by grace of God, we have that power in which we can do any job possible. So we may have to relearn and retrain ourselves. We must enjoy our life again. We can't. Many of us are in our 50s and 60s. We suddenly are left with a nightmare which is going to take away 4 years of a precious life. So we can't allow this to happen. So we must enjoy our life in real time. And we have to create new business stream. So this is my last slide. Steve Jobs said that you can't connect the dots looking forward. You can only connect them looking backwards. So, you can't know what is going to happen 2 years from now. 2 years later, when you look back, you can say, Acha, I should have done that way. Mr. Modi should have done that. But he doesn't know what is the right. So he is doing whatever he can for our country. So you have to trust that the dots will somehow connect in the future. So whatever decisions we take for this COVID, we have to trust in our decisions, and we have to pray to God that all these dots will connect. You have to trust in something, your gut, your destiny, life, karma, God, whatever. So this is what Steve Jobs had said, and it is so true even today for this COVID. And this is my COVID mantra. And I would like to thank you all for a patient hearing. Thank you.
Thank you, Rishikesh. Can I have the slides off? So let me have some quick rapid fire questions. One is that the virus does not cross and enters the semen.
Yeah, it doesn't most of the time, because there's no viremia, sir.
The virus does not enter into the ova.
Right.
Just go on speaking. Yes.
Yeah.
The virus does not cross the placenta.
Most of the time. There are some reports where it has crossed the placenta, but most of the time it has not crossed.
Most of the time it has not crossed. So IVF is safe in this time.
Right.
The chances of getting abortion are low.
Yeah, there's
if
no
you develop COVID-19 in the first 3 months, chances of abortions are
not there. It's a all or none phenomenon. If there is a early exposure, and if at all viremia, then it will abort. Otherwise, if the child will continue, there would not be much teratogenicity. However, the acute COVID was in March. So now by the first children that were exposed at that point in time will be born now. So we'll come to know whether there has been some teratogenicity or not.
So I want to add something to what IMA in its resource lectures has learned about the word positive, which you may appropriately incorporate in your guidelines. What does the word positive means? So we are talking about RT-PCR positive. After 9 months, when we know that RT-PCR can remain positive for 3 months, and we also know after 9 days the patient is not infected. So therefore, there may be large number of people who are RT-PCR positive but non-infectious. So nowadays we are doing RT-PCR if a patient is asymptomatic or if the symptoms are more than 7 days, then we do RT-PCR along with total antibodies, nucleocapsid total antibodies. And if the total antibodies are positive, we take it for granted this patient is non-infectious because already 9 days are over. That's second. Third thing we say is if the patient's RT-PCR is positive and the CT value is 32, 33, 34, then we know already 7, 8 days have happened. So appropriately, we may do one more RT-PCR, then the second RT-PCR may show negativity. Because when the patients are at the verge of becoming negative, their CT value of RT-PCR will be 32, 33, 34 with a cutoff of 35. Another thing is that those people whose RT-PCR is positive, and if their IgG is also positive as an antibody, then we presume that their infection occurred 4 weeks back. Initially, I was talking about IgG total. Now I was talking about total antibodies. So nowadays, if you really work hard on your patients who are positive, you may find actually 75% of them can be taken up for IVF. The confidence needs to be built up because initially everybody will be afraid, but the confidence needs to be built up. So in Delhi, what I do is all those people who have crossed 10 days and still they are positive in the family. So I call them for a cup of tea with me. I said, you come over, I have a garden outside, we will sit and have a cup of tea with you. So they built up confidence that after 10 days, the disease doesn't spread, even if you are positive. So the time has changed after 9 months for us to de-learn and not learn. So whatever we have learned, now is the time to de-learn and find out amongst those people who are positive. They may be positive, but they may not be infectious. So we have now IMA guidelines clearly available, which patients are positive but non-infectious. They should not be denied. Say, for example, a patient is coming for a cesarean to you, and she is positive, but her positivity is now 3 weeks, and you are shifting her in a COVID ward. It's criminal on our part to send a person who is non-infectious into a COVID ward just because the COVID test is positive. Because
Right.
after 9 days, she is non-infectious. For all practical purposes, she is non-infectious. So I'm only trying to say is because the time has come for us to redefine our guidelines, which were made 6 months back. And we will be able to help a lot because if a patient is coming positive and she is 3 weeks, she has a right to go for an IVF, unless we say no IVF for other reasons. So the definition of positivity is changing over a period of time. The second positivity change which has come from CDC in the last 2 weeks is initially we were saying that you need 15 minutes contact for a significant infection. Now CDC has made it 15 minutes of cumulative infection. That's the second thing they have done. And the third important thing which has come is subgrouping in a hospital. Subgrouping in a hospital means that suppose you have departments in the hospital, then those departments, interdepartmental people will not meet each other. So what they are trying to say is, suppose you have an IVF department, suppose you have 10 people working with you, then these 10 people will not mix with other people in the hospital. It's like a mini bio bubble. So they are picked up, they are dropped, they only meet each other so that if somebody adjacent person gets positive, your department doesn't get affected. So that's called as a mini segregation. we are advising them in the schools. So this recommendation has gone from us in the schools that if you have a school of 60 people, if in the same class, you segregate them into 15 each in groups, 4 groups in 15 each, their seats are fixed. They don't mix up with others. They play together, those 15 people, yet they sit in the same class. So you are mini segregating those people. That can be done in your department. But if your department mixes up with another department, then chances of closure of that department becomes very, very high. Another thing, I was interacting with Dr. Rajesh Malhotra, who is now the head of trauma center in Delhi. AIMS have procured the Abbott company's point of care test,
That
which
new
gives you
machine.
yes, which gives you the report within 5 minutes. A positive report in 5 minutes, negative reports in 13 minutes. So those can also be procured in the hospitals sooner or later, because the purpose today is to de-learn and pick up those people amongst those who are positive, who may not be infectious. And if you build their confidence, normalcy will come in the setup. So these are the new things which I wanted to share.
Yeah,
Over to Dr. Chokan.
I think it's a very good suggestion, and then at present we just want to not get them into the department. We just tell them, you come next time, we'll give you the discount. That's all.
Agreed. But what I'm trying to say, if we want to normalize the whole thing, situations are different. Now, why I am asking this is, I want to share.
You know, the problem we have got now is that we have to freeze the gametes. Now, then again, the problem comes that if you freeze them in the same tank, what is the, like, for example, when I have HIV positive patients.
So I want to show one thing is, I want to show why I am asking this question is, I'm going to take 2 minutes to show, to see, this is South Korea. You have a peak. There was a second peak after 3 months. If you see Iran, the second peak, the second peak is bigger than the first peak. If you see Italy, the second peak is bigger than the first peak. If you see UK, the second peak is broader and denser and bigger than the first peak. If you see Russia, the second peak is denser and broader and bigger than the first peak. If you see Japan, the second peak is bigger than the first peak. If you see Brazil, only 1 peak. If you see USA, third peak bigger than the second bigger than the first peak. Hong Kong, second peak bigger than the first peak. Malaysia, second peak bigger than the first peak. Philippines, only 1 peak. Singapore, only 1 peak. India, only 1 peak. We haven't seen the second peak as yet. You can see China, no peak at all. Australia, second peak bigger than the first peak. Singapore, only 1 peak. Pakistan, only 1 peak. New Zealand, only 1 peak. Bangladesh, only 1 peak. Taiwan, only 1 peak. France, second peak bigger than the first peak. Then we have Peru, second peak bigger than the first peak. Spain, second peak bigger than the first peak. Thailand, only 1 peak. Saudi Arabia, only 1 peak. If you say these are the second peak, then this is bigger than the first peak. So the answer is very clear that the second peak is going to come. The difference between first and second week is between 3 to 6 months. Second peak will be denser. Second peak will be wider. Second peak will be much more than the first one. Mortality, I'm working on the mortality formulation. So therefore, this is not going to be the end. This is, we are going through the first peak in the country. Second peak is yet to come.
Sir, what about vaccine? If the vaccine is given next month, then?
Rishikesh, I'm coming. The second peak is yet to come. It will come between January and February. And the second peak will be worse than the first. If you are saying this is an havoc, the havoc is yet to come. Now coming back to vaccine, a couple of things. The vaccine which is the most easily available, it has to be a killed vaccine. Killed vaccine from Bharat Biotech was available. They decided to launch on 15th of August. There was a media pressure on them. Even I spoke against it at that time not realizing that it was an inactivated vaccine. Inactivated vaccine may not require a phase 3 trial. It should have been launched in the country. China has already shown when they launched inactivated vaccine along with the phase 3 trial, they have shown it successfully. So inactivated vaccine should have been started and should be started at the earliest, even if it has to be given multiple. Another 2 vaccines which are going to come are going to have a problem in India, and that is Moderna vaccine and vector vaccine. Both the vaccines, basic problem will come is the legal challenge in the country. Who is going to pay for the side effects? Who is going to underwrite the side effect? That means if somebody dies out of that vaccine, people will have side effects. India does not have a no fault compensation policy in our country. So India will have to come back and say that if a vaccine is brought in India and if somebody dies or a side effect, the compensation is fixed like it is there in tubectomy program. In tubectomy and vasectomy, government has frozen the claim that you cannot get more than 30,000 rupees. Similarly, for a vaccination, because it is going to come in an emergency utilization certificate, compassionate use, liability will come on the government. So the government will come back with a compensation clause that till that comes, vaccine will not enter India. And it is an opportunity for Dr. Ashokan before he leaves. He still have 2 months. He still have November and December. This is the time for IMA to negotiate with the government because they are looking for a support. Government is looking for a support for a no fault compensation. So we can suggest, we can have a dialogue. We can call all the people, advise government how to bring a clause of no fault compensation. If that comes, it will come for not only for vaccine, it will come from all other medical problems also. Government is looking for an issue that is called no fault compensation policy, which is what all the manufacturers are asking, that if we enter into a country, we need a no fault compensation. No fault compensation means fixed price. That means if you want to take a vaccine, take it. If you die or if you have any complication, this will be the fixed compensation given by the government or by the WHO. That clause is not there, need to come. So therefore, if we are only depending on the vaccination, if we are only depending upon the vaccination, what will happen, we don't know. Vector vaccine have already caused 2 transverse myelitis. And Moderna vaccine messenger RNA, which is taking a big number. Both the vaccine of Moderna has caused such a severe shivering to one patient that in the night he broke open all his teeth. So both the Moderna vaccine, that type of a side effect may come, we don't know. So as on today, the best vaccine to bet is inactivated vaccine, which Indian government is afraid of launching it, took a back seat because of the media pressure. Dr. Ashokan.
Thank you, sir. That was an extraordinary enunciation of facts in such a short time, and the appreciation of the current epidemic across the globe. Thank you, sir, for that. And having said that, I wish to acknowledge Dr. Pai. For the past 3 or 4 years, we have worked together, and he has been a great friend of the Indian Medical Association, and he is actually one of the co-architects of FOMA. And we are grateful and we are looking forward to your tenure as FOXI president. Welcome to IMA, and we will meet again in the FOMA sittings.
Thank you.
Thank you, Dr. Pai.
Thank you.
Thank you. Thank you, Dr. Ashokan. Thank you, everybody. We will be back next Saturday with another show. Thank you.
Thank you.
Thank you, sir. Thank you, sir.